Chest discomfort, it's one of the most common reasons a patient will ever walk into an emergency room, and honestly, it's one of the toughest presentations we have to deal with. It's this true diagnostic crossroads where something pretty harmless and a full-blown, life-threatening emergency can look almost identical. So, okay, let's dive into this and build a really clear, systematic framework to get through this challenge.
First off, let's just get a sense of the scale here. We are talking about 6 to 7 million. That's million emergency department visits for chest pain in the United States every single year. That is a huge number of patients, and every single one of them needs a careful and efficient evaluation.
So, with all those visits, what's actually going on? This chart tells a really important story. Yeah, you can see that almost half the time it's a GI issue, something like acid reflux. But look at that big blue slice. Almost a third of these cases are ischemic heart disease. And that right there, that's the dilemma, isn't it? We have to be experts at finding the needle in the haystack, sorting through all the benign causes to find that one patient whose life is on the line.
So how do we actually do that safely and effectively every single time? We need a plan. The way I want you to think about it is like a diagnostic funnel. We're going to start by really defining the problem, then we'll immediately focus on ruling out the absolute killers. From there, we'll broaden our view, map out all the possibilities, gather clues from our workup, and then finally put it all together to make a confident decision. Sound good? Let's get started.
Okay, first, let's just take a moment to frame the problem. Why is this symptom, something we see literally every day, still one of the most high-stakes evaluations in all of medicine? And here we go. This is the heart of it. The challenge isn't just that there are a ton of causes, it's the incredible range of those causes. The person sitting in front of you could have anything from a simple pulled muscle to a massive pulmonary embolism. The stakes just could not be higher, because missing the bad stuff in this context, well, it can be catastrophic. And that brings us to our first and without a doubt most important job. Before we do anything else, our brain has to be absolutely laser-focused on the immediate life-threatening conditions. I want you to burn this into your brain. Think of this as your first 5 minutes checklist. The second you walk into that patient's room, you should be running through these questions. Look here on the left. Is the discomfort ischemic? That makes you think of a heart attack. Is the pain tearing through to the back? Now you're worried about an aortic dissection. Does it hurt more when you breathe in? That could be a pulmonary embolism. Systematically running through these killers is your #1 job to keep that patient safe right from the start.
All right, so once we've thought about those immediate life threats and we know our patient is stable, now we can safely take a step back and broaden our differential to consider everything else it could possibly be.
This right here is your roadmap. Look how it's organized by body system: cardiac, vascular, pulmonary, all the way down to musculoskeletal and even psychological causes. So, under gastrointestinal, you've got your usual suspects like esophageal spasm and GERD. Having a systematic map like this is so key to avoiding tunnel vision and making sure we don't miss something just because we were locked onto one idea.
Now this is where the real art of medicine comes in, using the details of the patient's story to tell things apart. Let's compare two cardiac causes that can be tricky: myocardial ischemia and pericarditis. As you can see, the quality of pain is a massive clue, right? Squeezing and tightness for ischemia versus sharp and stabbing for pericarditis. But what I find so fascinating is that the relief is often the dead giveaway. A heart attack gets better with rest. But that classic story of the pain getting better when the patient sits up and leans forward, that's your textbook slam dunk clue for pericarditis. These little details are everything.
And that leads us right into our formal investigation. How do we take all the data we're about to collect, from the history, the physical exam, our tests, and use it to really narrow down the possibilities? We all say it, right? The history is the most important part. But can we actually quantify that? How much does one specific detail, like the pain radiating down the arm, truly push the odds of a heart attack up or down? Well, the answer is yes, we absolutely can, using something called likelihood ratios. And this chart shows it perfectly. This is an incredibly powerful concept. Let's just look for a sec. See that top bar, pain radiating to both arms? It has a likelihood ratio over 4. That means if a patient has that symptom, it makes a heart attack 4 times more likely. Now look at the bottom. Pain that's positional or hurts with breathing? Their likelihood ratios are way below 1, which means they significantly decrease the probability of a heart attack. This is how you go from just a feeling about the story to using objective, weighted evidence. So for those patients where we're really worried about acute coronary syndrome, or ACS, our workup follows a very clear evidence-based path. It starts with an immediate ECG, is followed by serial high-sensitivity troponins, and then all of that gets plugged into a clinical risk score.
Let's just zoom in on troponins for a moment, because this is a huge takeaway. It is not about a single positive number. A patient with, say, chronic kidney disease might always have a slightly elevated troponin. That's what you see in the chronic injury part of this diagram. The big insight, the thing we are looking for, is a dynamic change, a clear rise or fall between measurements. That dynamic shift, that is the hallmark of an acute event, and that's what points us towards an MI.
All right, in our final step, we're going to synthesize everything, the history, the EKG, the troponins, to make a safe, smart decision about what happens next for this patient.
So how do we actually pull all this data together? Well, one of the best tools we have is the heart score. It's just brilliant because it's so simple and it's been validated over and over. It takes the 5 most important data points: history, ECG, age, risk factors, and the initial troponin, and it combines them into one single number score. This is what helps us get away from just a gut feeling and move towards an evidence-based assessment of a patient's true risk.
And that score translates directly into action. It's not just a number for the sake of it. A low score, something from 0 to 3, means a very, very low risk of a major cardiac event. A lot of these patients can actually go home safely. But an intermediate or high score, that tells you this patient needs to be admitted for more observation or maybe even needs to go to the cath lab. It literally guides your decision on what to do next.
So, the next time you walk into a room and a patient tells you their chest hurts, I want you to remember this framework. It's your best defense against both uncertainty and making a mistake. By starting broad, ruling out the killers, carefully collecting your clues, and then using a tool like the heart score to put it all together, you can turn that moment of uncertainty into an act of real clinical confidence. The key isn't to memorize every cause of chest pain. It's about having a reliable system to find the right diagnosis for the right patient at the right time.